everyone, and welcome back to the final session of this long COVID education day. Now, this session has been requested heavily, not just from therapists, but from doctors, nurses, and patients themselves. So, just got a bit of echo there, sorry. So we are going to be talking about vocational rehabilitation and return to work planning. And I'm delighted to have Kathy here as the co-chair, who has lived experience as a physiotherapist of phased return and return to work planning as someone who's living with long COVID. But I'm going to ask the panel to introduce themselves in more detail, and starting with Kathy as the co-chair. Thank you very much.
Hi everybody, thank you for inviting me. Yes, as Rachel said, I'm a physiotherapist. I work in an advanced practice role in MSK. I've got lived experience of long COVID for the past year and lived experience of several phased returns to work. I'm also part of the long COVID physiotherapy group and the MDT long COVID working party for employment, which is an advocacy group.
Thank you so much. Ashish.
Thank you, Rachel. Thank you for inviting me. My name is Abdul Ashish. I'm a respiratory consultant near Greater Manchester, Wigan. I'm also an NIHR Greater Manchester lead for respiratory research. We have had experience of running long COVID clinics since August last year primarily for the colleagues who work in a trust in primary care. So I'm here to share our experience. Hopefully it will be useful to those who are listening. Thanks, Rachel, for inviting me.
Thank you, and I can't wait to hear about your experiences for sure. Louise.
Hi, Rachel. Thank you so much for inviting me. I'm Louise Connolly. I am the professional lead OT for Herts Community NHS Trust. I'm an occupational therapist. I have been involved in the COVID pandemic response, initially supporting patients out of hospital, and then setting up a long COVID clinic with colleagues. We, like Ashish, we started our service in August this year. Thank you.
Thank you. And Jasmine.
I'm Jasmine. I'm an occupational therapist working in a outpatient vocational rehab department, and we've been helping people to get back to work with long COVID since around May last year.
Thank you. Now we're going to start the first presentation and take questions all at the end. And just while Ashish is loading his up, just a reminder, we do have full hour podcast specials on fatigue management, on breathing, etc. So please do visit the other sessions. This is a snapshot. I've asked give people 15 minutes to explain the last year of their lives and what they've been doing. So thank you so much for taking the time today. Over to you.
I'm a respiratory consultant in Wigan, and I'm here to share our experience of long COVID clinic. So for those who don't know, I see the audience is really wide. So I just geographically place ourselves. We are between Manchester and Liverpool. We have several. I was looking for claims to fame for Wigan, and we had many. So for those with the literary bent of mind, George Orwell, The Road to Wigan Pier, where there's a description of the coal workers around Wigan in the 40s. We are a very big rugby team, the Rugby League winners in 2018, Wigan. Those of you enjoy your baked beans, Heinz, with the biggest factory in UK and Europe. And we've got Uncle Joe's Mint Balls, Wigan Athletic, but most famous of all is the Wigan Pie, which I'm not sure outside of Wigan it's that famous, but here it is what it is. So today I'm going to talk about our long COVID clinic, why we set up, particularly the respiratory experience, and very briefly the rehab services experience. I know there's a lot more colleagues here who can talk about it more eloquently than I can, but here this is what we share today. So why did we set up our clinic? Back in between March and June, we were one of the trusts with hit really hard by staff sickness. About 500 of our staff were off sick after the first wave of COVID. And it was the highest in Greater Manchester, 15% of our nurse staff sickness, about 500 staff. And this was really out of proportion and a lot more than the other trusts across Greater Manchester. We had very great difficulty, and you can imagine the impact it may have had on staffing. So that's the sort of driver to think of a long COVID clinic for staff, to help them get back into work, and as a trust, as a gesture to say we care for our staff. So we set out to set this clinic up. Prior to that, we set out a staff questionnaire back in June. We asked several questions about the COVID itself, what they're struggling for, and what they would like to see in terms of clinic. We had 138 responses, of which majority of staff who responded to our survey were COVID positive. Only 2% of the staff who responded to the survey were admitted to the hospital, and majority, 2/3 of them, had some time off due to COVID. So in the survey that we found, unsurprisingly, there was a mix of symptoms, as by now we know, but severe fatigue was one of the most common symptom, about 40%, some breathlessness, about 40% again, sleep and mood disturbances, but they were not, and there was a mixture, a whole lot of mixture. In reality, it's usually is a mixture of things that people complain of. Mindful that colleagues need to know this is a working population. There's an acute trust staff and the primary care staff. So it's a different cohort of population, the younger population that we're talking about. So we can't probably extrapolate this to a generalized population. But if you're thinking of a working population, this is what we have seen. Predominantly females of the people who are still struggling with symptoms compared to males. And 1/3 of them, despite being at work or some form of work, were still struggling with symptoms. And that was about 4 months after COVID. A very small proportion consulted their GP, and 1/3 of them were just struggling with the work. They were in work, but they were not really able to cope. We published a paper with some of these results, and the link is as below. So I must mention this was for healthcare workers only. So we opened it up for the acute trust and for primary care colleagues in Wigan. We started this clinic in August of last year, and we had a multidisciplinary approach with respiratory. Us as 5 consultants, we were offering weekly clinic sessions. There was a rehab consultant who offered the rehab and chronic fatigue service, which we have. We had an occupational physician with us to sort out or look into any sort of work-related issues. We had a small team from psychologists, and in January of this year, we had ENT join us as well. So we opened it to all healthcare workers in the acute trust and the primary care, and they just had to do a self-referral to a generic sort of long COVID clinic at WWL. They could be referred by themselves, the line managers could refer, or even their GPs, as long as they're healthcare workers. We had this generic email triaged by one of our consultant colleagues, who then sent the onward referral to rehab or to respiratory, vice versa. So we had over 250 referrals, average age about 49 years. Majority of colleagues who self-referred themselves were females, largely non-smokers, and they were relatively fit, people with not really a great deal of medical comorbidities, as you would expect in a working population. So in the respiratory clinic, we've seen about 75 odd colleagues, again, non-smokers, a mix of nursing staff, admin, allied health professionals, and majority of them had COVID, which was PCR positive. Unsurprising, this is a surprising bit, that 70%, 2/3 of them didn't take any time off. And 20% of these colleagues who had are still not back. So if you extrapolate to a population, this is going to have a significant impact on our workforce, not just in the acute hospital setting, but everywhere. 20% of people, this is after 4 to 6 months after COVID, were still not back at work. So within our respiratory clinics, a majority of them, unsurprisingly, had the symptom of breathlessness of some form. But you could imagine that a lot of them had cough, chest pain. A third of them had breathlessness and fatigue. And a small proportion of them had anxiety and low mood as a predominant symptom when it came to our clinic. 90% had some tests, further test, chest x-ray, lung function. A fourth had HRCT, some had echo, exhaled nitric oxide, CTPA, and most of them had some shuttle walk test in the clinic, as we tend to do. So in this selective group of patients who are fit, who are non-smokers, who had COVID, who had breathlessness, it's reassuring to see 90% of the imaging investigations or lung function tests were normal. So really that is telling that this is a population that's working, they're young, they have no comorbidities, but despite months after COVID, they're still struggling with symptoms, but all the objective imaging and lung function tests were normal, 90%. What we found was a proportion of patients, colleagues had airflow obstruction or airway hyperreactivity. If you can go back, only 2% were ever admitted to the hospital. So again, this is not a population we are going to encounter in our long COVID clinics when we open them. Majority of patients have had suffered hospitalizations or been severely ill. But as we can expect, a big proportion may not have had any hospitalization. So from our clinics, we discharged 75% of the patients after the first review. A proportion were referred to rehab, chronic fatigue, and 3% to cardiac clinic. So without giving too much details, because this is 190 of our 250 went to the rehab services, and that's where I think majority of patients will find themselves ending up, rather than objective systemic problem. It is the deconditioning or the fatigue and these sort of symptoms that it's causing. And after half of them were discharged after one review, and the rest had some form of rehab between 2 and 8 weeks of rehab. 50% of those who are having rehabilitation or who required some workspace adjustments, and majority, and brief conversation with our rehab and occupational teams, about 50% of them had phased return. The details of what other work adjustments, majority of them had phased return, but there were people who needed changes in work environment. And I'm not privy to that data just as yet, but we're working on it. So from our experience, if you open the clinic, a lot of people who have suffered with long COVID will present to these clinics. I think objective testing may not be required for a lot of them. We have seen non-smokers and females, but if you open to a general population, the demographic might be slightly different. I think that predominantly the colleagues required rehab, dysfunctional breathing sort of setting. I think they needed help with that. Some psychological and mental health services are also key to those who are thinking of starting these sort of clinics. I think overall, about 20% will need work adjustments from our small limited cohort. So really, I think it's going to have a significant impact on our healthcare system for years to come. I think it's good to when we're setting up these clinics to collaborate with primary care, because a lot of these setting or patients would need mental health, psychological support, rehab, fatigue services, and a small proportion, I think a very small proportion, will require respiratory, cardiac, and other organ sort of clinics. I think the key is to collaboratively work with colleagues, allied healthcare professionals, primary care colleagues, rather than focusing on the secondary care side of things. And thank you. That was my slides. I'd be happy to be contacted. These are some of the details. Be happy to stop there now.
Thank you so much. And you were so right. That has beautifully set us up for the next two speakers, who are both occupational therapists. So thank you so much. Jasmine, we're coming over to you next. If you could start your presentation. Thank you so much.
Yeah, I'll just bring the presentation up. Hi, can everyone see that okay?
Brilliant, thank you.
Lovely, okay. So just to introduce myself a little bit, I've worked in the vocational rehab department since 2013, give or take a few rotations in the first few years. I've worked in occupational health for a couple of years, and in 2019 I finished a postgrad MSc in vocational rehab. Just as a quick overview of our service, we typically treat patients with musculoskeletal conditions, but we also accept patients with other issues, other conditions, if they haven't got a specialised rehab pathway. Normally, we approach it from lots of different angles. We do workplace assessments, functional ability assessments. We bring people into rehab and try and simulate some of the work-related tasks that they would normally do. We first started to get referrals through for patients with COVID in May, and we've since received 137 referrals. From the spreadsheet that we've got so far, 87 of those have been staff, and similar to the figures that other people have been mentioning, only 35 of those have been hospitalised. So a similar picture what other people are seeing, and we're pleased to say that 57 of those have returned to work in some capacity, and I think all the patients that have been referred to us have really struggled with symptoms and getting that under control. So we're really pleased to see that people are returning to work and starting to progress through those phased return plans. We were only speaking to the specialist OT, Sarah Holt, and she noticed the pattern very early on that it wasn't necessarily those people that were hospitalised that were struggling. It was those people that hadn't been hospitalised, that maybe they were still very unwell, but they had a relatively mild acute stage of the virus, but then were really struggling. So they seem to be the patients that we've had a lot more input with. I thought it would be helpful to just go through the relationship between health and work. It's not an easy decision for people to make as to whether they go back to work. People with long COVID are really keen to regain a sense of normality, to regain their identity, to integrate again socially with colleagues. And I think for many people it represents progress and recovery and brings back that routine. But I think what we're finding is also people are returning potentially some of the wrong reasons. And Dr. Asad Khan talked about it really well earlier, in that there's a guilt that a lot of healthcare professionals, especially, I think, are feeling that they're not supporting their team through the pandemic. And also pressure, and I don't think that's necessarily from managers and employees. I think it's more potentially it's all pressure from themselves, pressure because they don't always feel like they can maybe justify being so unwell because they had a relatively mild acute phase and they didn't necessarily need sort of the extensive medical intervention. But I think it's really important as healthcare professionals that we can try and help people to make this decision. So even if people want to return to work, it's having that conversation as to whether that's the right thing to do at the time. I thought it would be worth pointing out and going through a little bit about what a typical phased return looks like for those who might not know. So typically you're looking at reduced hours, adjusted duties, and normally the two combined. And depending on the organisation, a lot of people will potentially go through occupational health and have assessments and have recommendations that way. But often these returns are a fixed period. They're looking maybe 2 to 6 weeks, and there's normally a plan at the beginning, and someone will sort of progress through the hours, maybe starting on 50%, 75%, and start to begin to introduce more work-related tasks along the way. However, we found, and I think other therapists or the professionals have found that typical phased return process isn't working. I think it hasn't worked for people with long-term conditions anyway. And I think there are some key messages that we'd like to get across as a team, I think. Even for those healthcare professionals that have a really short amount of time, a 15-minute appointment where work isn't necessarily the main topic, And the first section I wanted to talk about was helping someone to decide whether they were ready to go back to work. And the first thing would be to assess whether someone has reasonable consistency in day-to-day tasks. And I think having bad days is to be expected, but it's looking at how bad those bad days are and how frequent they are. And if someone is having days where they're really struggling, they can't get out of bed, that they can't remain functional, it's very difficult to then plan a phased return, because we're not sure what to base it on. And we need to, before people go back to work, we need to reliably know that people can reliably go and attend each shift. The second thing is that people feel well enough to return. And I know that seems like a really obvious thing, but actually sometimes people can get very fixed on trying to increase their activity levels. I had a lady recently who was giving herself a little star on a chart every time she walked an extra mile, every time she did an exercise program. And that's the way she was judging recovery. Whereas actually at the same time, her health was deteriorating. When I asked her on a scale of 1 to 10, 10 being the best you've ever felt, how do you feel? And she was at a sort of 1 or 2. So I think as we look at the return to work plan, I think we found that you've not got to just judge it on level of activity. It's also if people are managing to maintain an acceptable level of health and well-being at the same time. And I think deciding whether or not you're well enough is maybe looking at that over a 2-week period rather than on a day. We know that people have good days or better days. And I think it's making sure that you've felt well, or patients have felt well over a longer period of time to be informed on that decision. The next thing is making recommendations about return to work. And I know, again, people might not have that time to go into really detailed recommendations, but I think there are some messages that we could get across through our AHP reports or our fit notes from the GPs. And the first thing being that if you were to write on that note that this phased return is likely to extend beyond 6 weeks, which it is needing to in many cases, if not months, I think not only are you sending the message of a time frame, but I think also in that message you're saying that this is something to be really mindful of, and someone isn't going to just go back to work and just get better. This is something that needs to be really well monitored. So I think you're sending 2 messages, and I think that can be quite powerful, even just that statement on a sick note. The second thing is for managers to regularly review this. People we know are having setbacks. Often the setbacks aren't associated with anything. They can be really difficult to predict. And what can sometimes happen is people will progress through their phased return and say they're due to start increasing their hours on Monday. Sometimes people will just go along with that, even if they've seen a deterioration in their health and they've seen significant symptoms. Whereas what would make sense is if a manager can review things really frequently, and if there is any sort of perpetuation, symptoms are getting out of control, that can be nipped in the bud much earlier, and it can potentially reduce the chance of someone then needing to have further sickness absence. I think patients are looking, managers are really looking to support their employers, and I think sometimes they feel bound to the policies that are a part of their company, but actually I think we underestimate the influence that we can have as healthcare professionals. I think if we're sending recommendations onto people, onto managers, they feel like then they've got the freedom to make the return to work plan a little bit more flexible, and they've got some evidence for what they're doing. I think it's very difficult, especially if managers aren't necessarily as experienced. They feel like they sometimes need to stick to these really rigid policies when actually they can use some managers' discretion on these things. I thought it would be helpful to talk about the AHP report, not just for therapists who might find it interesting and might be able to incorporate into their practice, but also for GPs if you're starting to see some of these come through. They do qualify for someone for statutory sick pay or for contractual pay. And if anyone's interested in that, I'm sure there are sort of training with different professional bodies. So I would have a look into that if you're interested. But I think this report's really nice because they're much quicker. Once you get used to them, they're much quicker than writing letters and reports. And it's really nicely aligned. It's really clear for managers to know what the patient's difficulties are. And that could be symptoms. It could be sort of functionally, they can only walk so far, they can only talk for so long. And then really clearly what your recommendations and goals are. I think therapists and occupational therapists were really uniquely placed to support these patients, and I think the more of these and the more therapists that are comfortable communicating with the managers, the better. Really, occupational therapists Of course, you need to look at the contraindications of the different sort of diagnoses that are coming through, but that's only a very small part of our assessment, I suppose. And I was only talking about this the other day with Sarah, in that we look really at activity, we break it down into its component parts, and we look at how we can use compensatory strategies, we look at how we can rehab people, and all those skills, especially at a time where those sort of diagnoses and that research are so limited, they're in such their infancy. I think it really is a time where we can help with this, really. So I would encourage people to look at this note or look at letters or anything like that, because we know that communication with stakeholders, with employers, it really can be a determining factor as to whether or not the return to work is successful. So if you have got a little bit more time, I thought it'd be useful to just go through some of our thought processes that we've had in our group rehab service as to how we come up with recommendations. And the questions I always ask are what are your symptoms, and understanding the implications on day-to-day tasks. So if someone's having sort of a vocal cord issue, it might be that they can only speak for a certain amount of time. And if then they have a job where they're looking at doing phone call triages, then they're going to struggle pretty quickly. So it's trying to identify what those lighter duties could be and making them really specific. I think it's really important to have that long conversation, if we can, with patients about what their symptoms are and what their work-related tasks are, and see where we think there might be a mismatch. Thinking about what makes their symptoms worse, what might help. And if you're at a point where someone is ready to go back to work and there is a little more consistency in day to day, people should have started to have more awareness about how they can manage symptoms. It might be that a really good night's sleep helps. It might be that pacing themselves and having regular breaks. And we can take what we know from home and from home life and take it to the workplace. One thing I would say is when we're talking to patients and trying to quantify what they're able to do at home is establishing what their comfortable maximum is. I think there's a difference between someone being able to walk for 90 minutes, but then needing days and days of recovery potentially to maybe walking 30 minutes quite comfortably, having a break, taking it easy, and then being able to walk again. Because what we're aiming for is not this extended recovery. We're aiming to try and ensure that people can do this day after day after day like that, like they will need to at work. So I thought I'd go through some of the possible adjustments, and these are really the ones that I found most effective. And I don't know about other therapy services, but the first thing is looking at shorter shifts. And I think not necessarily thinking that you need to start when you would normally start and end much sooner. If you were doing a couple of hours, you could maybe go in mid-morning. That would allow somebody to make up for potentially if they've had a bad night's sleep, and it also might allow them to do the school run, come home and have a little bit of time to recover and not have to be really tired, really symptomatic before they even start their shift. Non-consecutive days I've found have been really, really helpful, I think, for most people, really, if the phased return allows for it. I think undoubtedly with the best plan and with all that in mind, I think people are finding this return really difficult. It's really challenging, the return to work process. But if you can accommodate non-consecutive days, so work, say, Monday, Wednesday, Friday, at least you've got that day in the middle to have some recovery, and you can try and prevent that build up through the week. Allowing sufficient time before increasing hours. So there's always a temptation, I think, to try and increase hours on a good day. So if you think, oh, I feel really good today, so next week I'm going to push and I'm going to do 3 more hours than I have done this week. And sometimes that can lead to a tricky dynamic, because people then, if they do feel, things catch up with them and they feel like they can't do those hours as they'd originally suggested, sometimes it can be difficult for people to backtrack. So I always suggest that people do things for a couple of weeks, see how it goes, and at least then you've got a time frame where you've seen how you manage on a good day and a bad day, and make a more informed decision. I'm finding that I'm advising people to only increase to consecutive days when that recovery time is more manageable. If someone's working a Monday and then spending all day on Tuesday recovering and really struggling with day-to-day tasks, it doesn't make sense to then add in an extra day, especially because on a phased return, people are often not only increasing hours, they're also increasing duties. So the two combined can be really challenging. I think this is where sometimes we see those increase in symptoms and the sustainability of the return starts to be at risk. And finally, and obviously there are loads more adjustments, and it would be very individual to the patient, but the final one I've learned from really is setting limits. So managers will often say to people, oh, well, come in and just do what you can, which is really helpful. And I think it comes from a really helpful place. But in saying that, what you're asking someone to do is come to work and carry on working whilst they can until they can't anymore. And in doing that, you're waiting for your symptoms to stop you. Whereas if you can set limits on hours or duties of what you know is comfortable, you can hopefully leave your shift feeling well still. That's the ultimate goal. You want to go to work and feel well at the end of your shift and be able to go home and do your normal activities. And you want to turn into the next shift. So that accounts, I think, for hours, but also caseload. You know, have a fixed caseload. Say you do clinics, you wouldn't want to just keep seeing patients all day until you can't anymore. Try and set limits and pace them out a little bit, space them throughout the day. We've produced some videos at Group Rehab that were initially intended for staff at UHDB, but we thought they might be helpful for other people. Really sort of guiding people through the process, how to manage sickness absence, how to plan a return to work. And then there's also a video there to support managers. And these are presented by me and Sarah, but they take the experience of our whole therapy team. I work within an incredible team of occupational therapists that have done really good work and that are really forward thinking with this kind of thing. And then finally, just as a last slide, the longcovid.org is a fantastic support network, and there's lots of work being done to try and raise awareness of work. I think, you know, Claire Rayner and Richard Campbell have done similar work on the flexible return to works, and they've published an article, and it's great to see that as clinicians that what we're finding is also being published. So that's fantastic, and that talks about extending these phased returns, being more flexible, and some of the gaps in our knowledge. And I think just as a final take-home message, I just wanted to say that I think as healthcare professionals, we underestimate the influence we can have on employees, and if we can try and communicate with them more via letters, HP notes, fit notes, the things we say can really have an influence, because sometimes all managers and employers are looking for is just that evidence, that chance to be more flexible and move away from their sort of tighter policies. Yeah, thank you.
Thank you so much. Well, we all need a Jasmine, I think, and a Jasmine team in our services for sure. Lots of discussion on the chat. Thank you so much. We're going to come to questions at the end, and we're going to move on to our final speaker, last but by no means least. Now, Louise works in a brilliant community service. Like she said, she's got a wealth of experience in COVID, and she's going to present on behalf of her team. And yes, I'm delighted to introduce you, Louise. Over to you. Now we can see your presentation, but not your video or hear you at the moment if you're speaking, Louise.
Okay, can you see everything now, Rachel?
Yep, we just can't see your video.
Oh, okay.
But it's okay, you don't have to turn it on if it's
No, I'm trying actually, but you cannot start your video. Your host has stopped it.
I will try and ask you. There you go, I can ask you to start.
Okay.
What happens if you click that? Yeah, go.
Yes,
brilliant.
Great. Yeah, end of day. That's one of those things, isn't it?
Nice to see your face.
Thank you so much for inviting me. So I'm an occupational therapist. I've been working in rehabilitation now for the last 30 years, I think. I did my MSc in clinical leadership about 5 years ago, and I have been privileged to support the rehabilitation efforts for patients, as I said earlier, out of hospital in the COVID pandemic response back between March and early summer. We were particularly concerned, I think, as a whole team about the numbers of people that needed further rehabilitation, but also those people that had COVID that maybe weren't going into hospital and actually had rehabilitation needs. So as a result, we got together with, as an AHP Task and Finish group, we got together with our colleagues from secondary care, from the Mental Health Trust, our colleagues within our community trust, and we thought about putting our minds together about developing this long COVID rehab pathway. And I know we've been working with colleagues from UCLH, and I know they were there have been here today, and also our colleagues from Leeds Community NHS Trust. So basically our long COVID clinic started in August, and it's run by a GP, Harsha Master, and a COVID rehab coordinator who's an AHP called Alison Wilcox. So these are people who are in our team. So we have an integrated multidisciplinary team. We've got colleagues from the pulmonary rehab team, chronic fatigue, speech and language therapists, community therapists, dietitians. We have colleagues from the Mental Health Trust, which is the IAP team, some clinical psychologists, and we work closely with our colleagues from acute care, which is the Eastern North Hearts Acute Trust, and colleagues from PAH, and colleagues in social care and the voluntary sector. So we have really focused on trying to provide this coordinated, holistic care, offering both medical assessment and rehabilitation. And we've seen that importance of that symbiotic relationship, which I know we must have talked about today. And my colleagues presenting have also said that actually it's that medical assessment and rehabilitation working in tandem. So I thought I would just mention about the rehab coordinator role, just because this has been really quite key in helping to support people come back to work. So we have Alison Wilcox, who's a senior OT, who is supporting some of the triage of patients, but also working hard to coordinate that personalised, holistic rehab package across the pathway and actually signpost our patients into different modalities, I suppose, in terms of what they need according to their pathway. Because I think, as Jasmine said, and as Hashish has said, that actually that everyone has got their own sort of personalised need, and around COVID, because it's very systemic in nature, that no people have got exactly the same sorts of problems. So Alison has also had a lead role in sort of monitoring and coordinating our patients. We have a COVID-19 rehab register, and that's felt particularly important. And we have a weekly multidisciplinary meeting where we all get together on Teams with our partners and discuss our complex patients. And this idea about how we work across organisational boundaries, which Ashish was saying, has been really important. In a way, we're driving it from the community, but we're working with our colleagues in other sectors to support the best outcomes for patients. So we have a little bit of preliminary data. So some of the numbers might be similar to others. We've now seen about 437 patients through our long COVID clinic since we went live in August. I think the male to female ratio is probably similar to what other people have said, and some of the research is saying this: 2/3 female to 1/3 male. And we're seeing about twice as many women referred. And then our age range, which again is similar to other presenters, which is about 48. And in the main, it's white British. So we haven't necessarily had a significant number of ethnic minorities referred. So really going on from Jasmine's presentation about the occupational therapy role, I just really wanted to have the opportunity to share and maybe highlight to people that occupational therapy, people don't often realise that we have this dual training across physical medicine and mental health. And so certainly with the systemic and multi-system nature of COVID, actually, I think this integrated working as a multidisciplinary team and maybe as a system, but also some of the specific skills that occupational therapists can really help to support people's needs who have long COVID. So as Jasmine said, some of the ability to analyse and think about people's jobs in the context of their activities of daily living, and then be making the appropriate adjustments around people's work and home life, and always, as the whole team will, empowering patients to take some control in the context of everyone at the moment during COVID feeling quite out of control because of the pandemic. And certainly for us, with our patients, anxiety is a really significant feature, which obviously impacts on some of the fatigue and the brain fog. And certainly in the context of people returning to work, and what does that mean, both for their own safety, but also just about how they can cope. That's, you know, a significant consideration. So this is really just giving, we don't have a vocational rehabilitation service, and we've got, you know, limited occupational therapy resource within the team. But this is really, I know my colleague Abby was going to present today as well with me, and we have just reflected a bit about our experience and practice with some of the patients that we've been seeing, and maybe helping to give people a bit of a framework for consideration. So we are certainly no means experts, but then we've just thought about what we need to do both from a professional perspective, but also as a team, and how we can help people in terms of their recovery back to work. So I think, you know, as both my colleagues have said, this idea about acceptance, people understanding their symptoms and their current limitations, this is by no mean feat. This psychological acceptance and people actually stepping back and thinking about whether what they can do and be realistic in the context of returning to work, for some people takes a number of weeks, if not longer. And as Jasmine was saying, I think that as healthcare professionals, and we've had, I couldn't give you the numbers, but we've had a number of healthcare professionals who've come through the clinic, this expectation of yourself in the context of not letting down your colleagues, getting back to work, everybody absolutely feeling that lots of things are expected of them, both in the context of their work life and often their home life, actually accepting the limitations of your symptoms and how you're going to manage that has been, you know, really tricky. And I think certainly for members of the team, health coaching, giving people reassurance, supporting and validating their feelings about that, and people actually having lots of opportunity to just offload has been really quite important to help people accept where they are at now, and then maybe thinking about what they can do for the future as part of that plan. So I think Jasmine has also highlighted this beautifully, but actually some of the issues about balance and pacing, especially in the context of post-viral syndrome, I have been particularly interested in some of the issues around executive functioning and brain fog, and how that impacts on people's return to work, and some of those memory, concentration. Often when you're in a work environment, you're switching, aren't you, from one task to the other. You can be in a noisy environment, you can just have to manage lots of different, both mental and physical demands. So certainly balance, and that's balance in the context of returning to work, but also thinking about how that fits into your activities of daily living. Often, as you can see, you know, we have an age group on average, the 48-year-old woman, and actually people have got lots of other responsibilities, both for children, for managing the house, sometimes for elderly parents. So your work has to fit into the whole of your life. And then I think we have certainly felt that we've had a big role as occupational therapists, but also within the wider team, about supporting people adapt healthy habits. And in a way, probably having appointments with patients and colleagues who they have a little bit of accountability to us. So maybe we'll put in some sort of program and think about what might potentially work, and people will know that they might need to come back to us and actually think about putting that in place and then talking that through with us. So certainly having an opportunity to do that has felt important around supporting change. And I think that's really a lot of our experience. And yeah, you know, I think probably my take-home message is that work, it is certainly in the context of people's physical and their emotional well-being, and we just need to be thinking about how we can support people, not just in the short term, but also over a number of months. Thank you.
Thank you so much, Louise. And I'm going to welcome the speakers back for question time. Kathy, there is some questions in the chat. If you want to come on, and Louise, I'm just checking stop sharing your screen. Yeah, that would be great. Thank you. So there's lots of common questions. So I'm just going to, first of all, ask Jasmine the specific question with reference to the 50 people you referred to. How many managed to stay at work or achieve full-time working, please?
So we're yet to get that information. It's just information that we've tried to put through on a spreadsheet. So of the 57 that have returned to work, we're kind of hoping that most of them are still in work, because we leave them on an open appointment or for quite a while. We're always encouraging people to come back to us if they've got any issues. We really want to nip things in the bud if things are starting to escalate. So we would hope that those people are still at work, and otherwise we would know about it. But I can't. Sorry, it's just the data that we've collected on a spreadsheet.
It's okay. And just another one about your specific work. Do you offer regular reviews throughout the phased return, or is it an assessment only, then recommendations?
Yeah, so we review all the way through. Often we're seeing people at the minute for sort of 3, 4, 5 months before they even return to work, and we're tending to do the AHP report, which means we're reviewing things every 2-4 weeks anyway. We'll tend to review them a lot more frequently as we head towards the return to work, because we want to closely monitor any changes. And then as they return to work, we continue to review. We're doing a virtual group at the moment, which we're finding really helpful, where people, we talk about some symptom management stuff, but I think people are finding the sort of peer support more important. So people are giving us feedback through that as well. And then, yeah, we continue to review people. And we aren't a service that's set up for managing long-term conditions, really. So this is something that we've had a logistical difficulty with within our rehab, but our specialist OT, Sarah, is great. So we're adapting as we can and trying to review people as often as we can.
Thank you. Now, Kathy, over to you. We do have 10 full minutes for questions, everyone. So please do put any in the chat. And Kathy, I'll let you host the chat, and I'll pop some in across from YouTube if I get any. Thank you.
Thank you. Thank you to all three of you for some fantastic presentations. A lot of it really resonated with my own personal lived experience. It's highlighted the significant impact that long COVID has had on the workforce, and the need for us all to be able to address the return to work effectively. From some of the chat, I've picked up that perhaps we need to consider a different approach to our historic return to work, looking at an extended phased return due to the unpredictable, the relapsing, the remitting nature of long COVID. it gives us an opportunity to be able to rewrite the traditional model that we've had, which hasn't particularly worked well for long-term conditions in the past. We're exploring new territory with long COVID, and I think it's challenging for managers as well to be able to support the workforce. And I'm just wondering how we engage the managers as best possible. So perhaps I can start with Jasmine.
Yeah, thank you. Yeah, I think I agree with everything you've said. I think we do need to look at a return that's extended beyond 6 weeks, but also has that flexibility in it, and that we don't just progress things because that was the original plan. I think when we're looking at trying to make recommendations for patients to get managers on board, it's about making a case, and the things that I tend to bring up are, and I suppose it's key words really. So I always talk about improving the sustainability of someone's return. So ensuring or minimizing the risk of further sickness absence. On the return notes, I always try and mention about improving someone's productivity. And I think it's all the sorts of things that managers want to hear, because in doing this phased return, it's not just benefiting the person who's returning, it's also benefiting the company hugely, because otherwise this person might stay off work for longer, or they might be having multiple absences. So we talk about productivity, you know, if people are getting these rest periods and they're doing work that's well within their capacity, or what we hope is within their capacity, it means that they'll be much more productive. And I think if we're trying to get even an organisational level, if you're in an organisation and you're trying to initiate change, I think we can also look at trying to develop a case for that. So it depends what's important to the organisation. It's looking about brand image, you know, if there's ever a time to pull it out of the bag and really show that you're going to invest in your employees and look after the health of your employees, it would be now to look at, I mean, our organisation, our University Hospitals of Derby and Burton have been great. They've not requested that people use annual leave for phased returns, which has allowed for much more flexibility. They're looking at extended pay in certain circumstances, so people don't have that financial pressure to return to work as soon. And it's looking at what case you can build, I suppose, to try and engage that organisation and see how it would be a positive for them.
Yeah, thank you. The use of the AHP Fits note, I think, is a really good idea to promote as well. It helps, I think, with Louise's point with the acceptance, because if you've got the individual who's sitting down and working through the AHP note to be able to see what problems they may have, they can look at strategies to help them return to work. And it's a discussion point for the managers as well. So are there any other things that you'd like to add, Louise, to helping people with the acceptance and perhaps look at the problems they may have for the discussion with their managers?
I think based on some of my experience, and I was just thinking of one of the HCAs who we recently saw, who was going back to support the mass vaccination in a GP surgery. I think sometimes, some of it is all about the validation of symptoms. And actually, I think that really is very important, because I know sort of earlier in the day and last week at the Royal Society, they were talking about people sometimes not being believed. So I think that some of that acceptance and validation, and then just talking it through with somebody, is really important. But also we've been giving people, our patients, and everybody really, the Your COVID Recovery website, the NHS website, and actually often suggesting, and we've done this to teachers and we've done this to, say, one of our healthcare professionals, HCAs, you know, print that off and then maybe have a dialogue with your manager, because I think that even though long COVID is in the news, isn't it, that people have got a very mixed understanding about what it is. And I think that also the point we've made about this relapsing, remitting element of the disease, which is really quite key, is also helping people feel empowered that they can actually have these conversations at work, and actually, as well as them being informed, help to inform others about, and also maybe get help from other people in their team. And so that feels quite an important part of the acceptance, and then, yeah, for people to be able to get their head around it, really.
The Validation is so important, isn't it? Because it's a confusing disease.
Yeah.
And personally, sometimes the symptoms don't make sense to yourself. If I think too hard, my quads hurt. And I'm a health professional, and I know enough about the inflammatory nature and the systemic nature to be able to make sense of it. But if you're not a health professional, it's incredibly difficult with all of these confusing symptoms that disappear and appear. So yeah, I think that's really important. Ashish, would you like to come in on anything based with the rehab as additional comments? I think you're still on mute.
From our experience, I think a good proportion of patients will require some sort of rehab support for variable lengths of time. I think it's important to drive the message that you cannot do the traditional return to work approach in long COVID, because this disease is different. It's not, you cannot predict the future outcome based on what is seen currently, and therefore, as Yasmin has said, the managers need to know that there may be an extended period, and frequent reviews have to be part of this return to work. I don't think anybody's trying to con the system by saying, oh, my symptoms have come back, and there's no objective measures to measure it either. But from what we have seen in long COVID clinics, this is relapsing, remitting. Patients are ill and not functional for months and months on end. And we are very early on to identify this in any objective manner. So I think as a body, we need to recognize this, recommend this, that there's currently no objective evidence to measure and quantify how long a person is going to take, and therefore collaborative work between the occupational physician, the occupational therapist, and the team, and a sort of wholesome recommendation is what will guide return to work rather than a single aspect. And I think this sort of approach should be advised and recommended. And we as respiratory specialists who have seen most of these should be in the best position to give expert advice in where there is no formal guidance. That should be till research shows what approach should be taken. I think our experience collectively would reflect what is the right thing to do.
Yeah, we could potentially as a group be in a very powerful position to make change, which would be really beneficial for all people with long COVID.
Absolutely.
How are we doing for time, Rachel?
Last couple of minutes, but I think that's a great, there's lots of lots of chat about that in the group, isn't there, about who should be leading on this. And I think that's what you've just brought together nicely, the managers, the actual the human resource policies that protect staff, but often work against staff because they don't meet the needs of long COVID and what is needed to rehabilitate staff. And I think there's flexibility within that. Now, the joy of being a foundation trust is that you can adapt your policies to meet the needs of your organisation, and the same for community trust. But the reality of that is difficult without the evidence, isn't it? And I think that's what you were saying, Ashish, whether we come together as a respiratory specialist group or along with primary care, along with the fatigue specialists, and people like yourselves, Jasmine and Louise, and the professional bodies, so the societies, to say, actually, this is what we need. I think the problem is we need it now.
Mm-hmm.
So I don't know if anyone's got any final thoughts on that, how the people that are listening, that are maybe the managers, a lot of managers on this course, saying, how can I support my staff without having the framework or the policies that allow me to support as a manager? I mean, even just things in the chat about using annual leave, like I'm a manager, I wouldn't make my stuff use the annual leave for phased return, but I have the power to do that. But there's plenty of people that won't. So any ideas, tips to finish off? Maybe come round to everyone individually. Ashish, come to you, please.
I think it's a hard one to make any concrete recommendations. Apart from this has been the collective experience, and this has to be forming the framework of return to work for such individuals. I think compassionate leadership is absolutely required in these circumstances. Available evidence rather than hardcore research, randomized controlled trial evidence is what we need to go. And at the end of the day, we are trying to support our fellow colleague workers or patients to ease into work. Nobody wants to stay because it affects people's mental health. There's only so much of Netflix and things you can do at home, really. So I think a collective recommendation till evidence becomes available, a more compassionate and individualized approach based on recommendations from a collective team is what is required till we get there, till we have objective markers and how we can. But I don't think we'll ever get there, to be honest. This has to be always, this is what will form the basis of our recommendations to help ease people back to work.
I love that. I'm going to come back to one of your comments to finish. Louise, she will come into you, then Jasmine, then Kathy, if you've got any comments before we're finished. Louise.
Yeah, I mean, I agree actually with everything that we've just said. I think I would definitely say this call for compassionate leadership in terms of how we're supporting, certainly for our own workforce across health and social care, who've been significantly affected by long COVID. I think that also I absolutely echo this multidisciplinary approach in terms of how we support individualized and the best plans for people so it's successful. I think that's key. And then I absolutely agree too with our lived experience, both from our patients and also colleagues, about how we could create some sort of lobby, those people that have experience and those of our patients, that we could have some sort of frameworks for practice, which we don't have currently.
Thank you. Jasmine, coming into you.
Yeah, I think in addition, and really just echoing what Ashish and Louisa said, but I think it's approaching it from two angles. I think the more we try to communicate quite in a consistent message as healthcare professionals, the more we do that to employers and allow managers to develop a case to try and challenge some of the policies, I think that will be really powerful. And at the same time, I know Kathy will probably be in a better position to talk about what they're doing at a sort of a higher level to try and influence change from the agendas and things like that. So, yeah.
Thanks, Kathy.
Yeah, I think we need to move away from the historic models we've used. The old versions of returning to work on an incremental increase doesn't allow for us to be able to pace effectively. And a failure to pace potentially is going to lead to more disabling and longer lasting relapses, which was my experience. I went too quickly on a phased return and lost 6 months. I was off for a 6-month period. And if I'd have gone slower, looking back, it's easy to do that, of course. But if I'd have gone slower and not pushed quite so hard, I think I could have stayed at work without crashing so badly. I think we need to look at a different approach so that we haven't got that incremental push. And what are you going to do next? You're going to increase your hours. You're going to progressively increase. The approach needs to be flexible so we can allow for people to relapse, and you can have a regression approach as well as a progression. So there's an awful lot of work that I think we can do around that. And just finally, to wrap up, I think that one of the themes from today has very much been, let's get this patient-led. So I think the voice of the patient is paramount in all of these discussions. And I look forward to working with all of you guys to be able to move this forwards and get a better result for all of the people with long COVID who desperately want to go back to work.
Mm-hmm. So what a final session when there's a call for action. So Ashish, you're absolutely right. The professional organisations, the societies coming together, people living with long COVID. I mean, there is plenty of healthcare professionals that are living with long COVID. We've seen that from today and from some of the tweets in the chat as well. So I love that call for action. And I want to finish on that word of compassionate leadership. because that just absolutely melts my heart, especially from a consultant physician. And I work with many amazing respiratory physicians, so that just melts my heart. Thank you for that. Thank you for being there. Thank you all of you today, and for all of the speakers throughout the day. We're really, really grateful for